the garden variety SVTs. And there is a lot of basic electrophysiology here. This slide just shows, what everybody sort of recognizes on a 12-lead ECG as AV node reentry. And that's in the differential for these garden variety SVTs. Mainly AVNRT is the majority of cases you'll see, but orthodromic AV reentry using an accessory pathway and atrial tachycardia are the other contenders. And luckily, you don't have to remember much more than that. For the vast majority of cases, you're trying to sort out these three mechanisms. Along with junctional tachycardia on isoproterenol, sometimes it becomes a confusing issue after you've done a slow pathway ablation. But what we take advantage of to separate out these different mechanisms is sort of, are they reentrant or not? And AVNRT and orthodromic AVRT are reentrant, and they also both involve AV nodal tissue. So they're both AV nodal dependent and they're both reentrant. Orthodromic AVRT uses everything. So it uses the atrium, it uses the AV node, it uses the His system, the ventricle, an accessory pathway, and then it gets back to the atrium. Whereas AT only uses atrial tissue, so it doesn't care what happens in the AV node, doesn't care what happens in the His system, doesn't care what's happening in the ventricle. And these are the kind of important differences in the mechanisms that we exploit when we're trying to figure out what these tachycardias are. So we're going to start and kind of go in three parts. The first part is clues in sinus rhythm, where we can just look for certain things without doing anything at all, just looking at the beats go by. The other thing we'll do is pace in the ventricle and look at retrograde conduction. And then finally, we're going to look at observations during episodes of SVT and then pace during SVT if we haven't figured it out yet. So here, we're going to move on to what's one of the clues? Well, dual AV nodal physiology. We used to have to plot these curves in the EP lab. We don't do this anymore, really. We just look for the jump. But if you were to plot a curve of putting in A1-A2, which is the drive cycle, so you're pacing in the atrium, and then A2 is the premature, and then you plot that cycle against what occurs downstream, A2-H2, which is the output on the other end of the AV node. When you see a 50 millisecond jump with just a 10 millisecond decrement in A1-A2, that's what this curve would look like. You get at right around less than 400, you see a sudden jump in the time it takes to get through the AV node, which also defines the ERP of the fast AV nodal pathway. So that's clearly something we look for, because very frequently, if you have a jump, you're often going to be observing AV node reentry. But it's not the only thing you can see with jumps, because sometimes orthodromic AVRT requires a jump in order to initiate. So don't get fooled into thinking just because you have a jump that it's definitely going to be AV node reentry. It could be other forms of tachycardia. There are other evidence you can look for dual pathways, and in this case, I've drawn an arrow from the pacing spike all the way across one QRS to another His in front of the next QRS. And that very long conduction time, which is called crossover or PR greater than RR phenomenon, is usually seen only when you have slow pathways present and you can conduct one-to-one down that slow pathway. So if I were to come off pacing on this example, and I think we see later where I do, you'd see that long AH time. And that sort of crossover phenomenon is very commonly seen with AV node reentry, and it can be used as an endpoint, actually, following ablation. This is the first. If this is present before I ablate the slow pathway, I look to see that this crossover is gone after I ablate the slow pathway. It's a very good initial endpoint for slow pathway ablation. So then we begin to pace the ventricle, and we're looking into seeing what's happening retrograde. In this case, we can see that normally we would expect the His bundle catheter to be the earliest, followed by proximal to distal coronary sinus, and the high right atrial catheter to be late, sort of out somewhere in the mid-coronary sinus or sometimes even later, depending on where you put it. To see the right atrium line up with the hiss is funny, so we recognize immediately this conduction looks a little funny. The other thing that you notice is look at the P wave in lead 2. Upright. So, conduction through the AV node does not produce that. So this is an example of a sneak peek, I call it, when you're pace the ventricle and you see evidence that there's a pathway present just by the retrograde conduction sequence. And this eccentric right free wall sort of conduction that gives you an upright P wave inferiorly is a very important thing to recognize. Additionally, you'd like to see what's happening retrograde in the His. In this particular case, you don't really see the His bundle tracing retrograde. And in fact, this one may actually be capturing the His partially, even though it says it's in the apex, but it looks kind of narrow. So here we have eccentric retrograde conduction, very important initial finding. And you probably have a pretty good idea what you're going to find after that. The other thing is you will look for evidence of changing activation sequences, can give you a clue what you're going to find. So in this case, we have ventricular pacing and one-to-one regular conduction through the AV node, and you can see the His bundle. Atrial electrograms are small, but they precede anything else. They come right after the larger ventricular electrogram. Then you have a late high right atrial, and then you have sort of a slightly eccentric, but basically proximal to distal coronary sinus. And then suddenly, when you put in a premature after the drive, there's a sudden change in the activation sequence. So this would end the activation timing. The VA time gets longer, and the VA sequence changes. Now the His is later, and the distal CS is early. So this, again, gives you a clue that you may be looking at an accessory pathway. And you may need to do those kind of premature stimuli to bring out differences. The other thing we're going to be looking for in retrograde conduction is whether retrograde conduction is tied to the His bundle or not. In this example, you can see we're pacing the ventricle, and the His bundle catheter, where on the second beat, there's a little arrow that points out what is probably the retrograde His bundle depolarization. And because it's going through the AV node, it goes from V to His, and then back up through the AV node and depolarizes the atrium. So that you'd expect in this case the His A to be earliest, which it appears to be, proximal to distal coronary sinus, and the high right atrium's later. So that's concentric atrial activation. And then when we get put into premature, that little His signal disappears and it pops way out. We call it His out the back. So the His bundle electrogram gets later, and why would that be? Well, the reason is the shortest route to get through the AV node from the right ventricle is to go up through the right bundle, and then into the AV node, and then the atrium. However, when you bring in a premature, you may block in the right bundle. It has to go transeptal, up the left bundle, and then get to the His retrograde. So it takes a much longer time for you to do that, and that's why the H pops so far out. But when you see the His and the A go together, then you know it's AV nodal conduction. And that's really not, most of the reason that you get these jumps retrograde are not because there's dual AV nodal pathways retrograde, it's because you blocked in the right bundle. That's by far the more common reason. The HA time here is not really changing. So there's no jump in the AV node. The jump occurs because you blocked in the right bundle when transeptal up the left. And the A is tied to that jump. Here's an example where you see retrograde conduction is independent of the His bundle timing. You're doing the same thing. You're pacing the V, and you bring in a premature. But in this case, instead of the A jumping out with the His jumps out independently, and the VA time stays fixed, and the VA activation sequence, or the atrial activation sequence, does not change. So now we've proven that this pathway retrograde is independent of what's happening at the His bundle level. That's diagnostic of a pathway being present. Don't be fooled by slightly eccentric, sometimes wildly eccentric left atrial activation in the CS. So if you look at a CS catheter here, this is a case of someone in AV node reentry, and it just shows that, you know, with the proximal His and the mid His are about tied. So a lot of times I see people looking at this kind of activation sequence and assuming that it's a pathway. You cannot assume that. In the coronary sinus activation can be pretty eccentric and still be AV node reentry. It's not usual at all. It'd be very rare for it to be left free wall type activation. That has been reported, but this sort of slightly leftward activation in the CS is not uncommon at all for AV node reentry. The other way you can get this kind of funny activation is if you did a lot of ablation in the posterior septum, trying to either get a pathway or get a slow pathway, or sometimes you couldn't figure out the diagnosis and you're just bombing away back there trying to get rid of something. And I think this next example shows where this type of maneuver can be quite useful. So here's a case where the patient was referred to me for ablation, and they thought it was AV node reentry, and it turned out to be a pathway. And they had done lots and lots of ablation in the posterior septum trying to get rid of the slow pathway, but never quite hit the accessory pathway. And so the activation sequence in the CS looks very funny. It looks like the mid to distal CS is the earliest. And that doesn't really look like what usually is through the AV node, but after ablation in the posterior septum, you can't use the activation sequence in the coronary sinus reliably any longer. So what we did was put in extra stimulus after we ablated the pathway. We were wondering, is this remaining conduction up a damaged pathway, or is this just a funny-looking AV nodal conduction? And this proves that it's AV nodal conduction. Here we have a His bundle on the first beat. I drew a red arrow on the His bundle on the second beat. And then the third beat is a premature. The His bundle jumps from one side of the V signal to the other. So the right bundle blocked. It went up through the septum, up the left bundle, and now the His pops out the back. But the atrial activation is tied to that. So the His jumps out at the same time the A jumps out with it. They're tied together. So that proves that this is, although it looks funny, it's still AV nodal conduction. That's really important, and I would encourage you to start looking at retrograde conduction for a couple of reasons. One, it can make a diagnosis of a pathway, and two, it's on the boards, and it's one of the most frequently it's a question that people frequently get wrong. If you look at one of the biggest category for wrong answers is retrograde conduction when they analyze the board. So, and it's probably mostly because people don't look at it. So I think you need to do it in the lab to sort it out. Another useful maneuver is to do parahissian pacing. And when you pace near the His bundle, you really kind of see three families of QRS morphologies. If you get pure His bundle capture, you recognize, those of you who are doing His bundle pacing, you'll recognize that when you capture the His bundle directly, there's a little isoelectric interval, and then you see a perfectly normal QRS that perfectly matches the patient's QRS and sinus rhythm. For when you capture the His bundle and local right ventricular muscle, you get fusion. It looks like an accessory pathway. You get like a delta wave, a narrow QRS, and then when you lose His capture and only capture the RV, you get this wide one. This is how you can sort. You don't even need to see whether you're capturing the His on a catheter itself. When you put the catheter up in the His bundle area, you push it in far enough so that you don't capture the atrium, and you come on, you'll see these three families of capture. Not as easy to see pure His bundle capture, but you'll certainly see the two families of QRS fusion and RV capture alone. Here, we look at the possible responses to parahissian pacing relative to RV capture alone. So if you have AV nodal conduction only, then if we capture the His bundle, we provide a shortcut to get through the AV node. So the VA time usually shortens by more than 35 milliseconds. So we're capturing the RV, then we suddenly capture the His. We see a narrower QRS on the surface, and the VA time you will expect to shorten because that is by capturing the His, you no longer have to go all the way around through the His Purkinje system to get there. When you get His capture alone, you don't see any change in the VA time from RV plus His capture when you have AV nodal conduction, because again, the AV node doesn't care whether you captured the RV or not. It's going to get there directly from the His bundle capture through the AV node. So the VA time activation sequence will not change between those two conditions. Accessory pathway is a little different. It cares more whether you're capturing the ventricle. And these really hold true for septal pathways, not so much for the free wall ones. Although right free wall, this works. Left free wall may not, because the RV pacing is too far away. So this is really designed to sort out septal pathways from the AV node. And if you capture the His bundle in addition to RV, you're not going to see a change in VA time, because the accessory pathway cares whether you're capturing the RV, not whether you're capturing the His. The AV node cares whether you're capturing the His, not whether you're capturing the RV. However, when you do get His capture alone, you're not capturing any of the RV. In order to get an echo beat up the pathway, you have to come down through the normal His Purkinje and then echo through the normal conduction pathway. So you will get quite a big jump in VA time. And frequently, you may not even see an echo. When you capture the His bundle alone, it may not echo back up the pathway at all. Here's some examples. Nodal response. Again, in the middle, we see a wide beat. So you've lost His capture on that case. And you get a longer VA time. It shortens when you capture the His bundle, because that's what the AV node cares about. It's got a shortcut when you capture the His bundle. And this one shows an example where when you capture the RV alone in a nodal response, you've got this long route where you have to get all the way back down to the distal His Purkinje system, where it's no longer, there's no longer a sleeve of preventing you from getting into the His Purkinje system when it's distal near the moderator band. However, if you move and you capture the His alone, it's a more direct route. Doesn't matter whether you get fusion between that RV and what's coming down from the His bundle. That's immaterial to what's happening in the AV node. It just matters you captured the His bundle and went retrograde, so the VA time does not change between pure His capture and His capture plus RV. Then when you have a pathway, it's the opposite. So you get RV capture and His bundle capture, and there's no change in the VA time, because whether you capture the His or not doesn't influence the conduction pathway from ventricular muscle straight through the pathway. And so you can see in this case where the orange arrow is, the His bundle is no longer captured. The bead on the surface gets wider, and the VA time does not change, and the VA sequence does not change, because you're going up a pathway. So it didn't matter whether you captured the His or not. The pathway didn't care. The next slide, we see example of why that is. Straight route from RV capture through the pathway. And again, whether you captured the His bundle or not didn't really matter. It just went straight from the RV capture portion. But if you capture the His bundle alone, it's got to come all the way down the His Purkinje through the ventricle and back up. So it will change that time. And often you won't even see an echo in that case. When you're using Paracene pacing, you just have to be careful you're not capturing the A. That's the biggest pitfall. And you can use some timing to help you. So in this case, you can see when we're clearly capturing the A, because we're capturing both the V, maybe the His, and the A in the first beat. And the second beat, we're only capturing the A, and there's no change in the atrial activation sequence. So you can get fooled into thinking that there's actually retrograde conduction here, but there's not. You're only capturing the right atrium, or you're capturing the right atrium from the His bundle catheter. So when you have a stim to proximal coronary sinus less than 60, or stim to high RA less than 70 milliseconds, that's very likely to represent direct atrial capture. When the stim to proximal coronary sinus is more than 90 or more than 100 in the high RA, that's very unlikely to be capturing the atrium directly. So those are things you can use to sort it out. But really what you want to do is just make sure you push the catheter in far enough so that when you look on your His bundle catheter before you begin pacing, there's little to no A there. You're really probably capturing more the right bundle than the true His. But that doesn't matter. You can still use that. information. The one timing, so again, when you're talking about left free wall pathways, you will see small changes in VA time when the His is captured. This is an example of that, where when we lose His capture, the time, it's longer time to get there. And the reason is, when you capture the His bundle and you're pacing at a septum, it's a shorter route to get to a left free wall pathway if you capture the His, because it goes over the left anterior fascicle and right out the pathway. So it actually, when you're pacing the right ventricle, you capture the His, you are going to have a slightly shorter route, but not the kind of change of like 35 or more milliseconds. It's going to be in the sort of 15, 20 at the most, probably. Differential RV pacing is another thing you can use, and this is, I'm going to just try to make this very simple. Pathways insert at the base. If you want to get a shorter time, a VA time when you're pacing the ventricle, go to the base. So when you pace the base and you have a septal pathway present, it's going to have a shorter VA time than when you're pacing the apex. The opposite is true when you pace through the AV node, because the apex is closer to the His-Purkinje system, part of it that you can get into. And so if you're pacing the apex, you're going to have a shorter time through the AV node than if you're pacing the base. So they behave in opposite directions. You know, you can use numbers like this, but if you just remember that concept, you know, which one's going to be longer, then that's really the best way to remember it and not try to remember formulas or anything else. And when we look at this through the node, it's shorter when you pace the apex than the base. For the AV node, for a pathway, it's a little different. For a pathway, you pace the apex, it takes longer to get to the pathway than from the base. And so it happens in the opposite direction. Don't remember formulas, just remember that concept. All right, so all of that, we haven't even seen SVT yet. But this is important stuff. Retrograde conduction and how to evaluate it is really important for the boards, number one, and it's also important in real life because sometimes you can't sort it out any other way. There are a couple diagnostic findings you can get for orthodromic AVRT, just observing tachycardia. One is when you see ipsilateral bundle branch block causing prolongation of the VA time. And the second is HV prolongation that predicts an HA time change. And then I'll show you examples of those. But those are two very important things to look for because they're diagnostic of orthodromic AVRT. And these are other things you can look for. All of these things, VA time is very important because less than 70 excludes the vast majority of cases of orthodromic AVRT. There's some evidence that between 50 and 70 there's occasional patients. So less than 50 would be an absolute. Less than 70 takes out 99%. You're looking at activation sequence. You're looking at whether the tachycardia seems to initiate dependent on AV node conduction. You can look at wobble. You certainly want to look for AV block because that excludes orthodromic AVRT. And then the bundle branch block we talked about. So this is an example of initiation dependent on a critically long AH. This is similar, probably the same case I showed you earlier where there was crossover. Now we've come off pacing. We see a very long AH right before tachycardia begins. This is clearly AV node reentry and typical AV node reentry. But the initiation of typical AV node reentry is almost always dependent on a critically long AH. And we sometimes use that. So occasionally there's VA dissociation during AVNRT and you can't figure it out. And you have to use this finding where you see that it always initiates with a critically long AH and terminates with a short one. So those are the two findings that sometimes you rely on to sort out difficult cases. Here's we're pacing and we terminate it, and we terminate it with a short AH. If we had, on the previous slide, we showed if this had been induction, if we had been trying to terminate this with the same pacing drive, but tachycardia continued with this long AH, that would also be evidence that it's AV nodal dependent tachycardia. And then when we come on and we get the short AH, it terminates. So that's one thing you can do, pace just below Wenckebach cycle length, just below the tachycardia, and try to get it to terminate and see whether it terminates with the short AH or continues with the long one. Here's an interesting finding, and you might not, this wouldn't even probably cross your radar screen most of the time if you saw a tachycardia terminate like this. But what I want to make sure you always do when you're looking at board questions, number one, but also when you're looking at cases in the lab, is look at the surface first. So if you didn't look at the surface, you might not notice that the first two beats had right bundle branch block and the last one did not. So you look at the surface, you work your way down, you look at the V's, you look at the A's, are there hisses on the His catheter, and you want to try to account for everything, including the surface. In this case, we saw, tachycardia terminated with loss of a right bundle. Is that coincidence? No, because we saw it in this case multiple times. So this was a finding that happened multiple times. When you see this, this is fairly diagnostic of ORT, because SVT that terminates or the VA time changes when you develop right bundle or lose right bundle is diagnostic of ORT. Of course, the reason is once you lose the right bundle, there's a shorter route to get to the right free wall pathway, and it's still refractory by the time the orthodromic wavefront comes through. So in this case, the tachycardia was sort of dependent on having a right bundle branch block. Here's 2-to-1 infrahissine block during AV node reentry. So a lot of people, you look at this and you'd say, this is probably atrial tachycardia because there's block. Well, not always. One thing it definitely is not is orthodromic AVRT. You can't have AV block during orthodromic AVRT and have the thing continue. So you've ruled that out. In this case, you can see hisses. So it's infrahissine block 2-to-1. This is not that uncommon in the EP lab, particularly at the beginning of an induction. This is also pretty much a diagnostic slide here because you get termination of tachycardia with AV block. This is an important observation. And the septal VA time is almost 0 or even negative. So you've got a scenario where you've ruled out orthodromic AVRT by the VA time being so short, simultaneous VNA, and you've terminated tachycardia in the AV node. So atrial tachycardia is not going to do that. If it's been 1-to-1 the whole time, it's very, very unlikely atrial tachycardia terminates. At the same time, you produce conduction block in the AV node. So this proves it's AV nodal dependent, and it proves it's not, which is rules out AT, and it proves it's ORT because the VA time is too short. So this type of finding is you didn't do any maneuvers, but you know the diagnosis. Looking at wobble can be important. In this case, clearly the A's start to slow before the V's, and they predict every change in VV interval. The AA intervals predict all the HH or VV interval changes. That doesn't happen with AV nodal dependent tachycardia. It's very unlikely. Here's an example where there's linking between the V's and the A's, and all the changes are occurring at the AH level. So you get the HHs are now predicting the AA changes. So this is what you see with AV nodal type tachycardias. And this almost is another fairly diagnostic slide. The two things in this differential are pretty much, junctional is not ruled out by this, but the two things in this slide really are, is this atrial tachycardia or is this AV node reentry? And the wobble here gives you the answer because it proves it's an AV nodal dependent phenomenon. The V's and the A's are linked. Here, I gave you an example of a tachycardia that terminated every time there was loss of right bundle branch block. And this time, instead of terminating, the VA time shortens. So if it shortens with loss of right bundle branch block, you've diagnosed a right-sided pathway, probably right free wall. Look at the activation sequence. And this is a diagnostic finding. Here's another example with left bundle branch block. The left bundle causes a longer VA time. The loss of the left bundle, the VA time shortens. It's very important to understand where you're measuring VA time. If you drop a line from the surface QRS down and then measure to an A, make sure you're measuring to the same atrial activation on each of these. But if you were to measure the local VA time, it looks shorter on the one where the VA time to the surface is actually longer. Don't measure the local VA interval. That's not where you measure it. It's from the surface. You see the line we've drawn down from the surface over to the A. Same thing on the next beat. It's drawn down from the surface over. And that's clearly, you see the VA time shortened there. The local VA would fool you. Why does this happen? There's the usual pathway for left free wall, accessory pathway mediated tachycardia. If you were to get left bundle branch block, it's got to go down the right across the septum around. So the VA time will always change. Frequently, the tachycardia cycle length will change as well, but that's unpredictable because any lengthening in VA time can result in shortening of VAH, and overall, the tachycardia cycle length may not change, but the VA time will always change, and that's why it's considered diagnostic. This slide is just, hopefully they can get you these slides. I think that Kyle, if you're there, can answer whether these will be available. I don't want to go over every slide in excruciating detail. But,
yes, well, I'm available, not a problem.
Okay, so they can look at this and references about how much of a VA interval change you expect with bundle branch block during ORT. And the one other thing that you will occasionally see, and this was, Eric Brostowski gave me an example of this, where the HA time, when the HV time changes in this example, the HA time goes with it. So there's really not, if in AV node reentry this doesn't happen because the HV time is completely irrelevant to the circuit. You're not going to see HA time changes. Between the H and the V is irrelevant to the circuit. The HA time tends to be relatively fixed. So with AV node reentry, you don't see this phenomenon of an increase in HA interval preceded by an increase in HV interval. It just shows you that, again, orthodromic AVRT, everything's part of the circuit. So when you get a change in any component of the circuit, it will change your tachycardia. Finally, we get to maneuvers. And the two diagnostic ones to consider are the His refractory PVC that terminates SVT or delays the next atrial depolarization. These are the ones that you really have to look out for. Here's a PVC coincident with the His. We can see there's a His bundle electrogram there, but also it looks fused on the surface. So you know that there's part of the wavefronts coming through the AV node and part of it's coming from your pacing catheter. And it gives you that fused appearance on the surface and it terminates tachycardia. The reason it does, here's our cartoon again showing a left free wall. We're going to pace from the left ventricle. And we're going to see our pacing wavefront beats that tachycardia wavefront to the pathway, and the pathway is still refractory, and it terminates. That pace beat could not have gotten through to the AV node because that beat had already come through the AV node from the previous orthodromic wavefront, and that's why you get fusion on the surface. So the only place that this thing could terminate is within the pathway itself. So when you see this, it's diagnostic. You may get through, it may not be refractory, but if you can get through the pathway, advancing the A, and then you show that the tachycardia is permanently reset, so the next beat comes, equivalent to how far you advance the A, then you've also proved that's probably part of the circuit. And then finally, when you bring in a PVC on the His and you delay, and this is an example of, look how much later that next A came. Atrial tachycardia is not going to do it. You can't delay atrial tachycardia by putting a PVC on the His. This is another diagnostic finding because what happened was, instead of terminating in that pathway, you reached it, it's decremental, and when you reach it early, conduction slows through that pathway dramatically, and so the next A comes later than expected. Post-excitation, some people call it, but it's, again, a diagnostic. Termination, advancing and resetting, or delay are the things you look for. And here we have an example of resetting, where you have the cycle length of the tachycardia is 280. you advance the A by 20 milliseconds, but the next A comes at 280 again. So you've actually set the whole tachycardia forward by 20 milliseconds. If you had not reset it, that next interval would have been 300 because it would have equaled 2 tachycardia cycle lengths. If it's less than 2 tachycardia cycle lengths, then you know you've reset the tachycardia. We look for certain things with pacing during tachycardia. We look for an AAHV response or an AHV response. This is typical for atrial tachycardia if you're able to get through the AV node. The truth is, for most atrial tachycardia, when you pace, you get retrograde conduction block, so you get dissociation. That's the more frequent finding with AT. But if you are able to get through the AV node, what you'll see is an activation sequence that looks like AV nodal conduction, concentric, and then tachycardia resumes with the atrial beat conducting back to the atrium. So you've overdrive suppress it with pacing retrograde. This beat can't come back down through the AV node because you just went through it retrograde. The last beat, the third beat, can't come back down through the AV node. I keep thinking I have an arrow that you're seeing, but I now realize you're not. And then the atrial tachycardia resumes with its own different activation sequence. Here, it looks like an AAV, but you have to do the measurements. So that's how you sort out whether it's an AV or an AAV response. You pace your overdrive slightly faster than tachycardia. You see that you accelerate the A's to the pace rate, and you have to figure out what's the last A that you accelerated to the pace rate. That's the one you count. So the one that comes right after the pacing stimulus, that's not part of a VAAV. That comes from the last pacing stimulus, the second to last pacing stimulus. The last pacing stimulus produces the one where the arrow is pointing to. And so that's the last one driven at the pace cycle length. That's what you count, so it's a VAV. On the boards, they'll definitely show you something like that. Here's an AHV response. And this is what you usually see because most of the mechanisms are AV nodal dependent, not AT. So most frequently, you're going to rule out AT by seeing this response, a VAV. Here, we're going to talk about two things using overdrive pacing instead of PVCs. One is looking at the beginning where you look at the zone of fusion, and the other is looking at the post-pacing interval on stim A minus VA. This was the data when I was at Michigan. We looked at septal pathways versus atypical AVNRT where the VA time was more than 70 milliseconds. And stim A VA worked when you used a cutoff of 85, but there were a number of cases near the cutoff on either side. The post-pacing interval seemed to have a wider separation, and why most people tend to look at that and ignore the stim AVA, but I always measure both. You can also correct the post-pacing interval for the difference in AH time when you first come off pacing and when it's stable in tachycardia. You can subtract that difference from the post-pacing interval and get a corrected one of 110, very similar to 115. And this number, I think, is held up when people have looked at it in various studies. That 110 to 115 number has really been a pretty good one. When you have a pathway and you're pacing on in the same ventricle as the pathway, then you're going to get a short post-pacing interval. If you're pacing in the opposite one, you may not. So if you're pacing the right ventricle and you're looking at a left free wall, you may not get a short post-pacing interval. In this case, we see an example where we're pacing. We see on the surface there's fusion, so that's one criteria for orthodromic AVRT. We see the post-pacing interval is only 40 milliseconds longer than the tachycardia. We accelerated all the A's, and the VA and stim A are very close. So this catheter must be very close to the insertion of this pathway in order to have numbers that are this close to the tachycardia cycle length and VA times. When we're looking at AVNRT, however, you got to go up through the His-Purkinje system and back to your catheter again. And so the post-pacing interval is long, and it's generally more than 115, and I've never seen one shorter than that. I mean, maybe it could be close to that, but for AV node reentry, it's always longer than these numbers in the cases I've done. Here's an example of a typical AV node reentry where the VA minus stim A time is very long. You can eyeball it and see the stim to A time. And it's, again, it's a pseudo VAV, so you got to look at the second A after pacing. that time versus the VA time. And then post-pacing interval is also very long. That's what you expect to see with AV node reentry. Again, you can correct for the AH difference when you first come off pacing and during tachycardia. If you pace close to the tachycardia cycle length, you won't have to do correction very often. Again, if you pace from the RV or LV base, that probably gives you a better separation. But I think the best way to do it, honestly, this differential attenuation really makes the most sense to me. If you're getting numbers that are close to the cutoff and you can't sort it out, pace at the base and the apex. It's just like differential pacing. If you have a pathway and you pace at the base, the post-pacing interval should be shorter than from the apex. It's the opposite for AV node reentry. So it's exactly the same concept as differential pacing in sinus rhythm, except you do it with entrainment, and it's very useful. The other thing that you need to realize is that when you have a decremental septal accessory pathway, long post-pacing intervals may fool you. And that's the one case. So short post-pacing intervals, you're good. I've asked Fred Marotti again whether he's seen any since we've done this study. Never seen a short post-pacing interval that turned out to be AV node reentry. But if you get a long one, occasionally it can be due to a septal decremental pathway. And the way you recognize it even from the get-go is if the VA time's more than 40% of the entire tachycardia cycle length. Then you need to consider a decremental pathway, and you got to do other work other than looking at just the post-pacing interval. You can also look at post-pacing interval following PVCs, or when you induce tachycardia and aren't in training, and as long as you're pacing close to what your induction cycle length is close to the tachycardia cycle length, you can use it just like as if you're overdrive pacing. PVC is the same thing. And I'm going to skip that, trying to get through because we don't go too late. This is an example of the way you can identify whether you have fusion. So another criteria for diagnosing ORT is if you can entrain it with clear fusion. And you can tell that on the surface, perhaps, because you know what pacing looks like from that site in sinus rhythm. But sometimes that's a little confusing, and you can't tell, is this what it would look like in sinus? You're just unable to figure out whether the surface is fused because they all look the same. And it could just be constant fusion. But what you can do in this case sometimes is identify which hiss is driven by the last pace cycle length. So in this case, I'm showing the little hisses that you can see peeking out just on the other edge of the pacing spikes. And if you measure that hiss timing, the last one I marked with an arrow is driven at the paced cycle length. So what that tells you, it's not a retrograde hiss at all. You're driving the hiss orthodromically through the circuit by going retrograde through the pathway, through the atrium, and then down the AV node through the hiss. So that happens when you have fusion, because what's happening is you're not going back up retrograde through the AV node because the last wavefront has already come through the AV node, and what you're doing is driving it orthodromically through the pathway and then down to the hiss. And you can measure the HHs and prove that you have fusion during pacing, and that would diagnose AV node reentry. And this we published a couple years ago in Heart Rhythm. I'm going to skip all the description and just go straight into what this is. When you start to pace an overdrive pace on the surface, you'll get a bunch of QRS complexes that look fused. And here's a right free wall pathway circuit. And if we start to pace, you can see the QRSs start to fuse between normal QRSs and paced wavefront till eventually you get a stable morphology. Now that could represent constant fusion between the pathway circuit, and you don't know that for sure. But what I just showed on the previous slide, the orthodromic His activation could help you with that. Here we have constant fusion on the surface. So we've reached equilibrium between the circuit and pacing. You've reached constant fusion, what we look for with reentry. But when you have a left free wall pathway or AV node reentry, you have to take over ventricular activation completely with pacing. There's going to be no evidence of fusion at all because you have to get retrograde through the AV node to get into an AVNRT circuit. And to get way over to a left free wall circuit, you have to have almost no fusion. or at least not, you wouldn't be able to identify it on the surface. There's, for AVNRT, you have to get completely retrograde through the AV nodes. There's going to be absolutely no fusion in the ventricle when you affect the circuit. And this bears out in terms of numbers. So if you look at this, you have fusion during the whole initial part of the pacing drive, and we see that atrial activation changes. So we get advancing of the A during that period. That can't happen with AV node reentry because you have to get retrograde through the AV nodes. You can't have any fusion when you affect the circuit. And here's SVT terminating just like a PVC. It's the first beat of a drive, and you know it's fused because the next one's wider. Diagnostic of ORT. Here's delaying with fusion. So again, the very first beat that looks even a little bit fused results in an AA time that's markedly longer. Diagnostic. Again, look at the beginning of the drive, not just at the post-pacing interval. For AVNRT here, we see that you have to get to a stable, wide, complex paced beat before you start to affect the tachycardia. So it's got to get retrograde through the AV node first. Got to take over activation completely in the ventricle. Kyle, are we going to get cut off at a very specific time? How much time do we have left, Kyle?
We will not be cut off. We can continue. We have the agenda says till 8 o'clock, but we can run over. Not a problem.
Oh, till 8. All right. Jeez. I'm rushing here thinking that. Okay.
8 o'clock Eastern time. Sorry about that.
Oh, Eastern. All right.
No, take your time.
I'm almost done. I'm almost done. So, junctional tachycardia. So this, we see this very infrequently as a presenting arrhythmia, but very frequently in the EP lab because we give isopro. And, a lot of times we've done a slow pathway ablation, and we start to see some A on B tachycardia, and you wonder, is this just a damaged slow pathway producing a slower form of AV node reentry, or is it junctional? And there's a very easy way to sort this out with atrial pacing or APCs. And here's a schematic for how this works. So if you were to overdrive a junctional tachycardia from the atrium, you first have to suppress the junction so that you have to depolarize a His first, and then you come off pacing, and then what happens is the His fires again, or near the His, and you get retrograde conduction again. So you get an AHHA response, similar to the VAAV response with atrial tachycardia when you have a focus firing. However, when you have a circuit, and you pace the A, and you don't terminate it, you go down the slow pathway, which produces an H, and then back up, so you get an AHA response. I have some quick examples of that, and then we'll open it up. So here we entrain from the atrium during AV node reentry, and we can see that we pull in the His that's far downstream, so there's a very long AH time here, and the tachycardia continues. So you're trying to measure the H that's driven at the tachycardia at the paced cycle length. That's important because that's the one you have to count towards the AH response. So you have an A and H, and the next thing to come back retrograde is an A. So you're entraining this over the slow pathway. It produces A, long AH time, H, and then a retrograde A. Atrial extrastimulus works the same way. We bring in an atrial extrastimulus. It's the one downstream, far downstream, a long AH, where you pull in the His. And so that diagnoses the fact you probably have a slow pathway and you're pulling in the His. So it's probably AV node reentry. Here we're giving an atrial extrastimulus during junctional tachycardia. Here we affect an H that's close by, because you have to get into the junction. We pull that one in, and the next thing to come back is an H and an A. So you get an AHHA response with an extrastimulus. And you can see also if you happen to terminate AVNRT without pulling in the local His. So here we blocked in the slow pathway, but you can tell by the measurements we didn't affect the local His. So we couldn't have terminated a junctional tachycardia. We did not affect that nearby His, but we terminated in the slow pathway downstream. So I think the approach to SVT, first of all, is there a one-to-one AV relationship? If there's AV block, ORT's out. If there's AV block, it's more likely to be AT, but you still have to do a little work to make sure it's not AV node reentry. Septal VA time can help exclude ORT if it's too short. 50 is probably an absolute number. 70 excludes the vast majority. Atrial activation, concentric or eccentric. So eccentric is usually a pathway. Concentric, you got more work to do. Very eccentric, meaning free wall on either side. His refractory PVCs. Again, I told you what to look for there. Overdrive ventricular pacing, we just went through all that. But the important part to remember is if the VA time's more than 40% of the tachycardia cycle length and you have a long post-pacing interval, you need to put in PVCs or in train and make sure you don't have that delay. You don't see that during the fusion zone you get delay, or that a His refractory PVC delays the His, which would prove that, or delays the next day, which would prove that you have a decremental pathway. That's one of the harder things to sort out, and that's where entrainment or PVCs can help you. So I'm pretty much done. Why don't we open it up for questions?
All right, we did have a few questions coming in. First one here is from Dr. Akwawintalong. In your practice, how many atrioventricular extrastimuli do you do you give before calling it non-inducible SVT?
Oh, okay. Yeah, so non-inducible is a tough one. And there's some data that if you have very good evidence that there's a 12-lead ECG that shows it looks like it's probably AV node reentry, and then you have slow pathway, evidence of a slow pathway with an echo, that you can go ahead and try to get rid of that slow pathway in echo beat, even without inducible tachycardia. And that started, University of Michigan published a small series, and there was a larger series that confirmed that approach is good, if you have evidence that they may have AV node reentry. The problem is, obviously, some people can have slow pathways without any tachycardia, so you want to be sure that you document what their arrhythmia is before you bring them in. Because trying to get rid of the slow pathway completely has a higher risk of AV block, slightly probably, than just eliminating inducible AV node reentry, which is an acceptable endpoint as well. But you can't use that endpoint if you didn't have inducible AV node reentry to begin with. There are some tricks. I'm not sure there's a number of extra stimuli. I will often, we use this Michigan protocol where you put up to 4 extra stimuli, frequently even use that in the atrium. But I fuss a lot. I mean, I know that some of these people have AV node reentry and I want a better endpoint, and it can take a lot of fussing. Isopril on and off, different autonomic states, give a little atropine, burst pace very rapidly, wait for the effect to wear off because you can't get any block in the AV node. Pace the ventricle, looking for atypical forms of AV node reentry. You have to be kind of stubborn and do a lot of pacing sometimes to get AV node reentry to go. But I've spent literally 30 minutes or more doing nothing but pacing, trying to get patients in AVNRT. And then when they finally go, they go, and they become incessant frequently. But it can be very stubborn. And I think you need to use isopaternal, even though it's the most expensive drug on the planet. But it really, I did a case when I first got here of a patient who had an ablation elsewhere. They didn't give isopril, and they couldn't find anything. And once we gave isopril, we found the AV node reentry and got rid of it. So it's an important lesson.
Very good. Good to know. Another question that has come in via text here is from Lauren up in Minneapolis, asking what would be any recommended book or papers to prepare for the boards?
Yeah, so the boards, number one, I think the most, the plug for what we just did this past week, but the board review course has either, if you're going to take the test and, next year, you could potentially go to the board review course. It's a very intensive course, 3 to 3.5 days of intensive study. There's a lot of tracings in the board review course. So there's a practice test that has 100 different questions, and a lot of them will be tracings. We present tons of tracings in the workshops.